Our next speaker is Mazen Noureedin, whose interest is in metabolic liver disease and in fatty liver disease. Mazen trained in San Diego, was an NIH fellow, and did his fellowship training in San Diego and developed an interest in NAFL, and especially in imaging for NAFL and for NASH. Then was with us for a while at USC, but is now the medical director of the fatty liver program at Cedars-Sinai Medical Center. So we think Mazen is an excellent speaker this morning to review the AASLD abstracts regarding NASH and fatty liver disease. Mazen?
Thank you, John. Great picture in Dr. Rosen's presentation. All right, so I was given the task about talking about NAFLD and NASH in the AASLD abstract in 2019. Those are my disclosures. So when Dr. Parkhurst emailed me about this task, I looked and I found hundreds of abstracts, and I said, OMG, what do I do? Then I said, let's organize myself, and this talk is going to be clinical. I'm going to put you in the context of what Dr. Rosen started, and not just present abstracts. I'm going to present it in a way that you take home where the field is. So initially, okay, there are hundreds. Let's break it into natural history, diagnostic, and therapeutics. And indeed, what I did, this is my last slide. So this is my summary. If you want to take anything home, for natural history, fibrosis matter. Diagnostic, you're going to hear the word NIT. And this stands for non-invasive testing. And what we're going to do in the future, we're going to use either a combination of non-invasive testing or sequential. So we're trying to move away from the liver biopsy. And finally, with the therapeutics, you will likely have the first drug approved in 2020. So this is the development in this year. That was presented in EASL. Dr. Rosen highlighted it. It's obeticholic acid. So the two big news therapeutics this year, obeticholic acid, just published in The Lancet this week, showed fibrosis improvement. On the other hand, selonsertib unfortunately failed the phase 3 and 4 trial in the STELLAR 3 and 4. Yet that trial was very informative in the natural history. So when you see STELLAR 3 and 4, this is F3, F4 study, and enriched the natural history very much. So there are also races for other drugs that are now in the pipeline, and there's so many of them. But again, I have to remind you that because of the hundreds of abstracts, I'm also on race. So buckle up. We're going to go through the abstracts. This is Dr. Parkhurst gave me 2 minutes, so he is going to have the ride with me. So let's do that. So natural history, fibrosis matter. So this is what Dr. Rosen just showed, why fibrosis matter. 2 studies showed. Once you hit the F2 and above, morbidity and mortality increase, and especially when you get to the F3 and F4. And I'm not going to present history. The reason why I presented this because the NASH CRN Clinical Research Network had their long study presented in the AASLD this year, and this is a 2,000 patient that were followed about for 9 years. And as you see, this started increasing in F2 and above, but this is prediction of mortality. People with cirrhosis, they had higher relative risk of mortality, 4-fold more, which is not surprising for cirrhotic patients with NASH. Again, large study followed by 9 years from the largest network in the world, which is the NASH CRN. Well, they also found that HCC risk is increased significantly when you reach to F3 and F4. And this risk was about 9 times more than the lower grade of fibrosis. So again, fibrosis matter for mortality as well as HCC. Diabetes, as was mentioned in the first talk, diabetes is a risk for non-alcoholic fatty liver disease. And they have multiple studies looking into that. This study included 214 patients and looked at the prevalence of non-alcoholic fatty liver disease in diabetic patients. So they did MRI-PDFF to look for fat, which is very accurate, and they did MR elastography at the same time to look at the prevalence of fibrosis. And when they found that 64% of diabetic patients above age of 50 in primary care setting, they have non-alcoholic fatty liver disease. So just imagine these endocrine clinic, they're full, like almost 2/4 of them, they have non-alcoholic fatty liver disease. 11% have advanced fibrosis, which again correlates with morbidity and mortality and HCC risk. Moving on, Dr. Rosen touched base on this for a second, and this actually was a very interesting study, the bariatric surgery study. So a lot of people, when I give a talk, it's like, what about bariatric surgery? What about bariatric surgery? So a lot of us had actually questions about this one was presented and paused a little bit, and it depends on the way you look at it. So Vlad Rizzo and his group looked at their bariatric surgery cohort, and they had 866 patients. What they looked in particular is 181 patients with F3 and F4. So they wanted to look at the advanced fibrosis patient. They had a biopsy at baseline, and after 6 and so years, they had a follow-up biopsy. And out of the 188, 166 had a follow-up biopsy. And what they found that, as mentioned, 45% did not improve their fibrosis. As mentioned earlier, the predictor of not having improvement in advanced fibrosis was actually the sleeve. So the sleeve did not do too well versus the Roux-en-Y actually did well. So some people thought that 45% is a negative study and the fibrosis don't improve. On the other hand, you had people improve. And the take-home message, the sleeve gastrectomy was not as good as the Roux-en-Y, and it really depends how you want to look at the glass. If you want to see this as a positive study and a negative study, but something to keep in mind. Let's move to the diagnostic non-invasive testing. You're going to hear the word combo or sequential therapy. So combo, what we're trying to do is to combine these tests to reach high accuracy. And sequential, same idea. Instead of combining them at the same time, you do one after the other to reach the accuracy of a liver biopsy. Let's see what was presented. Before that, I want to give you a summary. You see the AASLD errors? Those are the 4 endorsed by the American Association of Liver Disease. FIB4, NAFL fibrosis score, transient elastography, and MR elastography, and the previous talk gave an introduction on those. I want to keep you or take you to these 2. They are very promising. You will see them. ELF is coming to the United States. It's a combination of these tests. It's an accurate marker of predicting fibrosis. Tons of abstracts are coming on ELF. You're going to hear about ProC3. It's a marker of type 3 collagen as well, and it's also a promising marker for fibrosis. So you're going to start hearing about these things in the future, especially the ELF. So why we need non-invasive testings? On the right, I think we'll all agree this is cirrhosis. On the left, I think between F3, F4, not so much. So we have variabilities, we have side effects for the biopsy, and more importantly, you have all these people with NASH, and you're gonna have treatment in the future, and you're gonna start treating them. So it's like having all these people on an island, and there's a fire on the island, and you want to rescue these people with liver biopsies with these 2 boats. So I'm not sure the liver biopsy will get the job done, and that's why we're moving to non-invasive testing. When you talk about non-invasive testing, you want to look at 2 things. One, the job of non-invasive testing in diagnosing your disease accurately. 2, in monitoring the disease longitudinally. An example will be A1C, will give you an idea about the disease. Improvement in A1C will give you an idea, initially A1C how bad, and then improvement will show you improvement. So you will hope that in invasive testing, one of them or a combination of them will do the job for both. But sometimes you need to have one for each. So let's look at this abstract. It's called NAFL Simulator. So this is a formula that came from MGH. What they did is you enter the patient information on NAFL, you give them the fibrosis information and the patient characteristics, and they will tell you a risk of having decompensation and HC and CC and mortality. So quite helpful there. It's going to be probably ready to be online very soon. Moving on, it was mentioned that microbiome matter. So in this study, they did, from UCSD, they did a combination of microbiome and metabolomics from the blood to distinguish cirrhosis from no cirrhosis. So it's a diagnostic test. And they combined these two actually with albumin, and they achieved a high area under the curve of 0.9, distinguishing cirrhosis from no cirrhosis. So gut microbiome matters. It can be a non-invasive test to distinguish cirrhosis from no cirrhosis, and more data is coming in this field. But let's go back to actually the ones that you're going to see very soon in your practice, especially when we have medications. So this abstract was on the left, the Target NASH. Target NASH is a real-world network that look for NAFL patients. And I put on the right, or I had this on the right, the STELLAR-3 data, which is, again, the solonsertib failed trial showing you like it enriched the natural history. So the performance of FIB4 NAFL fibrosis score and VCTE. So the real-world experience performed a little bit less than the clinical trial. However, like FibroScan, for instance, or transient elastography here was not, the number of patients was not as many as that we had in the clinical trials. So things to keep in mind, and also because the performance is getting less, that's why we're trying to combine or do sequential testing. And this takes me to the next slide. When you do NAFL fibrosis score, or FIB4, it's going to give you this first area. The FIB4 tell you, oh, it's high, patient has advanced fibrosis. Or it's going to tell you, oh, FIB4 is low, no advanced fibrosis. But in between, if you do the calculation, you will have this indeterminate area that you then like, what do I do? So here studies started recommending either do combination or sequential testing. So if your FIB4 falls here, do another one, transient elastography or FIB4. An example here, like look at the transient elastography to predict advanced fibrosis or cirrhosis. It was very good, but when they combine it with another test, it increased the fibrometer in this case, which is still not widely used in clinical trials or research, it increased the accuracy. So just an example how the field is moving toward this combination of testing. The ELF I told you is very promising. I'm sure you're going to see it very soon. So the ELF, I showed you the components of it. It's a serum combination of serum biomarkers. And this phase 2 study that we were part of it included 161 NASH cirrhotic patients with portal hypertension. So ELF at level of 11.3 and above at baseline predicted outcomes, including ascites, varices, worsening of the MELD and child score, as well as hepatic encephalopathy. Versus less than 11.3, it did not predict. That phase 2 was the Galactin trial. Moving on, this is the other studies, STELLAR-3 and 4. Also, they looked at ELF, and what ELF higher than 11.3 predicted disease progression here in red, versus the lower values, actually less than 9.8, predicted improvement in fibrosis. Again, show you new ELF as a predictive non-invasive testing of the disease severity as well progression. Along the same line, here non-invasive testing at baseline, here you have the ELF more than 9.8 or transient elastography more than 9.9 predicted disease progression F3 to F4 in this the STELLAR-3 and 4 trial, which was a very large trial. Unfortunately, it was negative. I mentioned to you the ProC3. The ProC3 is a test that it's a type 3 collagen. I'm not going to go deep into it. You're going to see it. More studies are coming. But in this study, ProC3 distinguished NASH from no NASH, and it has a very good ability in predicting fibrosis as well. So keep these tests in mind, ELF as well as the ProC3. This is a study we did from multi-center from 300 patients. So a lot of you do not, those that they have transient elastography, they say, well, the FibroScan showed me a value of 14, and I thought the patient is cirrhotic, but then I did a biopsy, and the patient was only F2. So what you can do actually, to increase specificity, increase this value from 14 to 17 or 18. But that will get muddy a little bit. So what we did here, instead of increasing values, we combined FIB4 to it, or NAFLD fibrosis score. So with that, we increased the specificity to 90%, and we did not have to go up on the transient elastography value, showing here you, for example, for stiffness of 8, when we combine it with FIB4, we reached a very high good specificity value of 90%. So that was a formula that we will publish online soon. This is invasive, but this is a really abstract that got a lot of attention. Biopsy is still required in all phase 3 trials, and it's one of the primary outcomes. So this is AI, artificial intelligence program that was developed, and it reads the biopsy for you. So what they showed here, that that program agreed with pathologist number 1 and pathologist number 2 very nicely. And in these trials, we have 2 pathologists around the world, or 3 reading all these trials. So maybe the machine one day will read these in a very accurate manner. And I'm sorry if there's a pathologist here. Maybe we will not need them. Or one time a machine, or one time probably I will not be here and a machine will be talking to you about this talk. So moving on. So what we've been lacking in this field actually is the non-invasive testing is very accurate diagnostically. And we've been waiting, okay, show me how it improved the disease, how it correlates with that. And we didn't have them simply because we didn't have a lot of positive trials. But since now we had the obeticholic acid as the first positive phase 3 trial that it will be likely FDA approved, showed that some monitoring data. So here, Dr. Rosen introduced the study already to you. So the dose that worked, 25 milligram. And look at FIB4, APRI, CK18, and FibroScan. Within 6 months, all of them dropped in compared to the placebo. Also, the transient elastography at 18 months, which is when they did the second biopsy, also dropped and was statistically significant compared to the placebo. But now also, how about the responders? So this is the data, non-invasive testing in responders to obeticholic acid. So on the top you have FIB4, on the bottom you have transient elastography. Sorry for the slide. So the FIB4, here you have one-stage improvement of fibrosis. So you see both FIB4 and transient elastography are dropping. Here you have worsening, so both of them are going up. So that correlates with biopsy. What was interesting here is this no change in fibrosis, and you saw a little bit signal here that the FIB4 and transient elastography, they were not as bad as the placebo. So on biopsy, at least this is stabilization of the disease, but maybe the non-invasive testing are telling us a different story, but that needs to be explored. So that was the obeticholic acid trial, which was actually, that was the same concept for the STELLAR-2. What they did here, transient elastography and ELF, they compared the biopsy, and they saw how much they predict other clinical parameters, such as change in weight, ALT and AST, and both transient elastography and ELF did better than the liver biopsy in predicting other clinical outcomes. So as you see, we're trying to move away from liver biopsy. I still think will be used at one point, but that's what we're trying to do. So the big therapeutic things. Again, 2 phase 3 trial announced, 1 positive, 1 negative. The negative was very informative for the natural history. So between Dr. Rosen's talk and my talk today, it's very clear that the F2, F and above patients are the target for therapeutic therapies. Indeed, now all the phase 3 trials require NASH was F2 and above, and that's what's entering studies nowadays. So I'm going to talk to you about medications in these studies, but let me just touch base really quick on outcomes so we understand how to read these studies. So this is a phase 3 trials. What we do nowadays, we looked for 2 outcomes in the trial. One of them will make you drug positive. So fibrosis improvement, you improve by one stage and you shouldn't worsen your NASH, or you have NASH resolution in simple words that your steatohepatitis should go away, but your fibrosis should not worsen. So either you hit fibrosis improvement or you hit NASH resolution. And this is what the obeticholic acid did. In phase 2 studies, what we look, as Dr. Rosen mentioned, MRI-PDFF improvement, change more than 5% is absolute, and we look at this 30% relative change, and we say how many patients improved in this 30%, and ALT improvement as a secondary outcome. So let's take a look. Those are the drug mechanisms. We'll go through what was presented, and there are multiple mechanisms, multiple targets, simply steatosis, inflammation with many pathways, as well as fibrosis. Just a quick slide so you know where's the field going. Those are the medication now in the phase 3 studies. Selonsertib fell off, obeticholic acid is positive, we're waiting on lofibranol and CVC coming very soon, and these newbies just entered the phase 3 trials. So let's talk about FXRs. So what was presented in this meeting? The FXRs play a role in inflammation, fibrosis, lipid metabolism, glucose metabolism. Dr. Rosen alluded to that. This is the phase 3 trial that was presented in EASL, now on Lancet, 10-25 milligram, the placebo. The reason why I put this here, because there was an abstract in the AASLD meeting. So this is what was presented in EASL, F2 and F3, and this is the improvement, 23% on the obeticholic acid, 25 milligram compared to placebo. But in this AASLD meeting, in contrast to this F2 and F3, they also looked at the F1 that they included with the F3s, and it did not change. They had 21% improvement compared to 11%. What they found that the NASH resolution actually was statistically significant. So here kind of they had 2 points when they included F1 patients in this trial, and that was statistically significant compared to placebo. We will likely not treat F1 patients in the future, but just like a way of analysis. One thing about obeticholic acid, that 50% of patients itch, and they have change in the lipid panel. And the next study in the AASLD meeting looked at the effect of itching on these patients using patient-related outcomes. So patient-related outcomes, the patient report if he's feeling good or not. So this itching within the 6 months was actually bothersome to the patient, but what they tried to say here, the patient-reported outcome at 12 and 18 months didn't matter so much. So maybe not so bad in the day. We'll test that ourselves when it becomes in clinic. Very impressive results also with another FXR agonist, tropifexor by Novartis. And this is a phase 2 study, an extension from their previous studies. They did hit a significant reduction in MRI fat fraction, and it was 65% of their patients achieved 30% and more. And they also had change in body weight and improvement in ALT, and it's predicted that tropifexor is going to go to phase 3 moving on. You're going to hear about ACC inhibitors. What's the ACC inhibitor? This box here shows you what's called de novo lipogenesis in the liver. De novo lipogenesis basically making fat in the liver. And this is one of the pathways. And one of these enzymes is called ACC. So if you have an ACC inhibitor, you stop making the fat in the liver. And we heard about this drug that was already published in phase 2. Now we're waiting the combination therapy with it. But Pfizer had their compound, and they presented in this meeting with very impressive results. So they had multiple doses, and they had a placebo. And what they found here that within 6 weeks, you see these drops, almost like at the 25 and 50 milligram, 87 and 90% of the patient achieved more than 30% fat reduction within 16 weeks. That's a very impressive number. They also had change in ALT and AST, and one of the mechanisms of ACC inhibitor that it increases triglyceride, something to keep an eye on in the future, that they have to mitigate that in trials and decrease HDL-C. And as Dr. Rosen mentioned, cardiac mortality is very important, so that needs to be worked on in the future. Moving on to the PPR agonist, pioglitazone as an example, there was a positive study from the Zydis, saroglitazar, and this is alpha and delta, and that what it does, this receptor improve many things, including lowering triglyceride, increasing insulin sensitivity, and let me show you their data. That was a 16-week trial on 106 patients, and their outcome, actually, they chose it to be ALT, and almost half of the patient had improvement in ALT on the 4 milligram dose. They also had reduction in MRI-PDFF fat fraction. So that drug was actually also positive and were likely to move phase 3. Dr. Rosen had this table. Those are the medication. I told you about these two. Others like GLP-1s. Those were mainly diabetic trial that they looked at secondary parameter, was not designed for NASH. So we'll see those in the future. But those 3 impressive drugs were there with significant reduction. Here you see it in MR fat fraction with more than 30%. Selonsertib, as I told you, it's ASK1 inhibitor, was presented in this meeting, and it's F3, large F3, F4. Unfortunately, it did not achieve the primary outcome. The drug has failed, but many stories have been learned from the natural history. Another one, caspase inhibitor from Kinetis, has also did not achieve the primary outcome, and this drug is dead now. So it's not bad to have failures because it teaches us, and this is what the field looks like. If you want to understand all the drugs nowadays, you have to understand which family has each member, who married who didn't. So that's how it looks like. But the idea is these families sometimes get along to each other, and they get married to each other, but that you can combine. And what we're waiting for now is the ACC inhibitor and the FXR combination in the ATLAS study that is going to come now. And as Dr. Rosen mentioned, you want to hit multiple markets, steatosis, inflammation, and fibrosis. Nothing better than finishing a talk for gastroenterologists with endoscopy. This is endoscopy. Some people just start waking up. So this procedure is duodenal mucosa resurfacing. It causes hyperplasia in the duodenum. That was a very nice 12-week trial that they did it in uncontrolled diabetics, and it changed their A1C, but also within 12 weeks, they had change in their fat fraction, which was a very positive study, and I'm sure I'm going to get a lot of questions about this one later. So again, that's the summary slide. I told you I'm taking back to this one. Natural history, fibrosis matter, non-invasive testing, NIT. You're going to hear this word a lot. Combination or sequential therapy. And we're going to try to move away from the biopsy. The first drug is going to be approved in 2020, first phase 3 trial. The other one failed. There are multiple in the pipeline. We have learned a lot. And there's a race for other drugs, and there's a combination there. And Dr. Parkhurst, although you give me 25 minutes, I made it on time, so thanks for the ride.